Hi, everyone. Okay. Hi, so my name's Izzy Mark. I am a psychiatry registrar. I started training in psychiatry in 2014, but I've taken quite a few years out I did the teaching fellow job at George's last year. So you might recognize me from that. You might recognize me from having done a specialist visit in PICU if you have, because I've been doing that this year. So yeah, from last year, I also started being an honorary clinical lecturer at George's, which I currently do 1 day a week. And yeah, that's me. If you want to ask more questions about psychiatry and my career, then you can. I'm sure you don't really want to know about that. But the reason why I'm here today is because I'm amazed. I'm very impressed that you all want to do this with your evening. A student who I did one of the SSCs with last year, I think, thought that I would be good for this, and I thought I've got lots of resources which I can share with you, so we can work through some of them today. This idea, obviously, it's very much a taster. It won't give you all of the information about psychiatry that you might need to know for exams, but hopefully it will start spurring on some revision and reminding you if you're on the right track or not, or what else you need to focus on. And so the way this will work is it's going to be a quiz-based session, which I think is hopefully what you were expecting. There's going to be two types of questions here. I've got some written poll questions, which Sophia will kindly put up on the poll when we do those. But there's also quite a few questions that are written questions, and you'll need to get some paper and a pen if you haven't already got one, because it's not just a one answer as well. So get like a good amount of paper, because there are like short answers where you have to write things here, and you'll get more out of it if you have a go and just see what you remember and test yourself with that. If you remember, I'm assuming you're in PE, you might remember my pub quiz style for the lectures at the beginning of the year. It's kind of a similar format to that. So hopefully you remember that fondly and are up there doing a bit more of that today. It's a bit more focused this time, obviously, as you've done your placements. We're covering the following sections. So psychosis, mood disorders, organic presentations, which are going to cover delirium, but also... Okay, I will wait a second for that. Delirium and alcohol as well, risk assessment and psychiatric medications, and then we'll do a question and answer afterwards. Sophia, do you have any comment on why the sound isn't working? We were obviously talking. Is my sound okay to you, or do you think...
It's okay. I think for the person who's having some sound issues, if we just quit and then join again, it should resolve it. If it doesn't, just message me.
Can you hear me okay?
I can hear you okay.
Okay, great. Do answer. I put things in the chat as we go along. I'm happy to make this a bit interactive and to go with that. Also, we're going to have to take a break halfway through, which is often a nice thing. So I'll try and find a good point to do that, because the BMA want to say a few words to thank you for your presence and things like that. So I will, find a point and we will do that as well. It should be an hour and a half, this session, with questions at the end. So hopefully by now, with me talking, everyone's good to go and everyone's got paper and pen and everyone's spurred on, ready for this. Obviously, it's a friendly thing, so just give it a go. I don't really care what the answers are or if you get the right one or not. Okay, so we're going to start with psychosis. And we've got a poll to start with. So I need to be able to see my screen here, don't I? A 52-year-old man with schizophrenia says that his ex-wife, his ex-wife is the doctor looking after him, and he's very concerned that she will be trying to access his money. He's very agitated, not able to be reassured that the doctor is actually a professional who he has not met before and is not his wife. What best describes this psychopathology? So what term would be the best one to use with describing the mental state, and this was the problem? just give you a few seconds to think about it. And Sophia can share the poll when you're ready. Okay, that's interesting. So can you all see that as well, I'm assuming? So a mixture between B and D, 48% equally, and one person who said C. So the correct answer is D. So well done for those of you who got that right. So delusional misidentification is typically when people think someone is someone else, and even though they don't look like that person, they think they are that person. So often it's exactly a case like this, where they say, I've met you before, I know you, I met you last week and you stole money from me, or you said something really nice to me, or whatever. That's normally what happened. Would it be worth higher looking at your settings? So someone who's just having difficulties with volume, or maybe try putting in earphones. Sorry, hopefully the rest of you can hear me okay. So that's delusional misidentification. Delusional perception is another one that quite a lot of you said, and yes, they're seeing something, so I can understand why you might have said it's a delusion of something they're seeing. That's not typically the definition of delusional perception. Delusional perception is normally you see something or you perceive something. So it might be seeing, it might be hearing. You perceive something, and as a result, you think something delusional as a result. So the very typical example is the traffic light scenario. So say the lights went green and I knew the Messiah was coming, or the lights went red and I knew I was going to hell, or that's obviously a particular type of delusion, but anything a bit like that. So you're perceiving something and as a result you think something. So this is a bit different. It's seeing someone, but you're seeing someone, you just think they're someone else. And it might not be that seeing them leads to you thinking that. You might just think that as part of the delusional thought process that's going on. Delusions of reference is normally watching something on the television or the radio, or reading something and thinking it refers particularly to them. So that's what delusion of reference is. And I will discuss the others in the following scenario, I think. So thought insertion is when people put thoughts into your head, or the idea that people are putting thoughts that aren't their own and they're having those. Somatic passivity is a bit different. I think I'm going to come to talking about that next, which is possibly giving something away, but we'll see. Might not be. I might be giving you a red herring. So this is the second poll. He then starts shouting, I don't know what to do, doctor. I know that she is controlling my actions using special radio waves, and there's no way I can get away from it. So could be a bit of debate here, but which one would you pick to describe this one? And like I said, I could argue it in a few different ways, but there is one answer I'm more thinking of, so I'll just give you a moment to think about that one. So yeah, I possibly led you down to that being the answer. So controlling my actions. If someone is controlling your actions, passivity is the word used for controlling. So they might have passivity of mood. So someone's controlling their mood, or someone's controlling their thoughts. So passivity of thoughts. Actions is more something physical, so somatic. So if they're controlling my actions, it's most likely somatic passivity. However, you could think it was a few other things. One I was thinking of was the one that two people got, C, delusions of reference. So that would be the radio waves are there, I mentioned. So when people feel like something in the radio is particularly referring to them, could be delusions of reference. Because of the control element, I would have gone more for passivity, but that's a reasonable choice. Delusional perception, again, it's the traffic light scenario. So one thing that they're seeing or hearing leads to something else. So this is more part of a delusion than thinking about control than that. And thought A, insertion. So it's, I suppose, the element is control here, and passivity is like control. So I'm not I can see why you might have potentially said thought insertion, but that's not so specific from this particular example, and there would be a better place to answer there. Does anyone want to share in the Q&A why you thought something else, or if there's anything else there that you were wondering about or a bit unsure on? Like I said, do ask questions to go along. I can carry on. If not, hopefully I'm with everyone. Normally I do this on a bit of a chat thing, so I am hoping that you're going to write stuff to share or tell me if you're ready or if you're a bit confused about something. So, next stage. So this is where the pen and paper comes out. Okay. So, defining a delusion. Hopefully you know a definition for a delusion, which is something that then, if you were in an OSCE scenario or whatever, you would be trying to show that all of those points are in place if you're wondering that someone has a delusion. So what would be the criteria for a delusion? So you get 3 points for that. The point thing is so that you can keep an eye and just adds a bit of fun competition. I'm hoping that at the end you can share how you did, and someone can be congratulated and they don't win on anything, unfortunately. But so have a go at thinking, what points would you say to define a delusion? And then if you've written something for that, number 2 is 2 characteristics of what would classify an obsession or an obsessional thought. And if you don't know this from a textbook, just have a think about an obsession and what that might mean, but it can occasionally come up in an exam. So we're on psychosis still. The obsessional thought one, you could argue, isn't quite part of psychosis, so I'm sorry if that was a confusion. 3 types of formal thought disorder. So what would you say for that? So, and I don't want to give you any answers, but there should be a lot of different terms that you've heard of to describe formal thought disorder, and different types, or if you're given a phrase, what formal thought disorder is that most like? And sometimes that can come up in MCQs or SBAs. So give me 3 examples for that for 3 points. And then the second one is give me 2 types of an auditory hallucination characteristic. So how would you describe, or if you've got someone who says they're hearing voices, how would you further define that? So 2 different types. I think Sarah Curran has covered this in some of her lectures, for those of you who might have gone to those. Okay. So this is the last one for psychosis. So thinking about schizophrenia as a long-term condition and prognostic factors is something that is quite a key thing, and it's an easy thing to ask about, so it could come up. So 3 prognostic factors for poor prognosis in schizophrenia. So what might suggest a poorer prognosis in schizophrenia? Not necessarily a trick question, so just go with what you think. All right, so I did make this 4 points initially. So you can get 3 points. Obviously, it's a maximum of 3 points for defining a delusion. So number 1, it's a fixed belief. And number 2, a false belief. So if you've got one of those 2, you get 2 points. It's firmly held despite argument or challenging or evidence to the contrary. So if you're doing an MSc and you've challenged it, so that's quite unlikely because of this. Have you thought of an alternative explanation? And they are completely fixed. It's fixed, but it's firmly held despite challenging. So that's number 3. And number 4, it's out of keeping in a person's social, educational, cultural, religious background. So if you've got 3 of those are 4 things, obviously in bold, so make it easy for you. If you've got 3 of those, you get 3 points. If not, count up the number you've got. In terms of the obsessional thoughts, and I'm sorry, this is not typically psychosis, although sometimes it can merge with psychosis, which can be quite confusing. I imagine that's probably going to be beyond your exams, to be honest, but you might have a non-psychosis related question. sorry, how do I mean out of keeping? That's a really good question. So I'm assuming, I'm not sure if you can all see that. I'm assuming you can, but the question was, what do you mean by out of keeping with a person's educational, social, cultural background? So what I mean by that is it's not something they believe normally in their life. So they might be, I'm really strongly conservative, and I think David Cameron is the best person ever. Well, it's not David Cameron, Boris Johnson is the best person ever. And I mean, he's amazing. He's going to save us all. If this person was a really strong conservative beforehand, that might not be such a bizarre thing. But if actually that's completely against everything they would normally stand for, then it would meet this criteria. If someone is saying they're communicating with God and they're hearing God talking to them and they've got the special mission to spread God's word and they were never religious before, then this might be, probably a bit of a grandiose delusion. If actually they're incredibly religious and have always been religious, then this might not be quite so bizarre and it might not meet the criteria for a delusion. So I hope that makes sense. The obsessional thought, which is the second one, so there are various criteria for this. And like I said, sometimes this can overlap with psychosis, but for you, I imagine this might come up in anxiety disorders. And there are various criteria for an obsession. And sometimes they might ask you why it's something as obsession versus a delusion. So you just stick with the criteria. So you've got the criteria for delusion there, and the criteria for an obsessional thought is that it is their own thoughts. It's in keeping with their own identity. They have insight into recognizing this. Often in an obsessional thought, they're normally distressed by them. They don't want this obsessional thought. They're fighting against it, which is quite different to a delusion where it's quite fixed and it's a firmly held belief. Normally what happens in an obsession is they might try and resist it because it's an unwanted thought. And this might can overlap with a compulsion, like in OCD or obsessive compulsive disorder. And with an obsession, it's normally a repetitive thing. So it keeps on coming back no matter how much they fight it down. A delusion sometimes comes and goes depending on someone's nature of psychosis. So it's a minor point, but sometimes it can come up. I've only put 2 points on it though. So if you've got any of those two criteria, you can give yourself 2 points. Otherwise, give yourself 1. Might be a bit of a hard question depending on what you've been revising so far. Okay, keep on writing things in the chat if you've got any questions. Otherwise, I will go on. So I've got a question. Is this compulsion the need to act out that obsession? Is compulsion the need to act out an obsession? Obsessed about being clean and therefore being compelled to disinfect something? Absolutely, yeah. So normally a compulsion is the need to check, the need to clean, and it's a sort of to relieve the obsessional thought. It only relieves it temporarily. Normally, it might give a temporary relief, which is really reassuring, which is why they keep on that compulsion, but it doesn't last and the obsession continues to come back. You can sometimes, though, have obsessional thoughts without compulsions. They're not necessarily going together, but normally to have a compulsion, you have to have an underlying obsession. So I hope that answers your question. But yeah, thanks. Keep coming the questions because it means it's nice to have that interaction for me and hopefully for you as well. It makes it more worthwhile if I'm answering your questions directly. So hopefully for thought disorder, you knew that this was the sort of thing I was meaning. So there are different types of thought disorder. A common question, which I've come across a lot in the last year, is, particularly when I've seen people on PICU, is that people say, right, what type of thought disorder do they have? That's not really how thought disorder works. People generally have a whole mixture of all of these different types at different times, but they might say one phrase that is, that's flight of ideas, or that phrase, that's night smooth thinking. So in your exam, you might be given a particular phrase and say that's that type of thought disorder, but generally you're not going to have one patient just with one type of thought disorder. So that's I think that's a good learning point, because I know a lot of people have misunderstood that when I've come across people this year. If you want to ask any questions on that, please do. Are there any people, please do mention if there's anything else on the list that doesn't come under the formal thought disorder list. I see there's also a question about hallucinations. I'll get to that in a minute. Circumstantiality. So, good question. Sometimes it's called circumferential as well, and it's worth different things. But essentially, circumstantiality is they're all part of psychosis. You ask someone a question and they go round the houses. They don't just answer your question like you would probably like them to or expect them to. So they'll answer it, they'll go, you'll think, where are they going with this? They'll go round. This might be psychosis. It doesn't actually have to be psychosis, because you might know some very talkative people who do this. Eventually they answer your question. It might be 5 minutes later. It might be after they've talked about, I don't know, what they did yesterday and the weather last week and what they're doing going on holiday, and then they eventually answer your question. So I always imagine it like a circle. They've gone full circle. So hopefully it explains that. How do I explain these formal thought disorders? Formal thought disorders is part of psychosis. So normally there are 3 elements to psychosis. Hopefully this rings a bell. You'll have delusions, hallucinations, and the formal thought disorder. If you remember your mental state, thoughts can be divided up into thought form and thought content. So the thought form, we're normally thinking about, is it an ordered, logical, coherent thought stream, or is it disordered, of which we'd normally say it's formal thought disorder. Thought content refers more to the delusions, and then obviously in hallucinations come under abnormal perceptions. So it's a feature of psychosis. So circumferential. Sometimes people say circumstantial. It's the same thing, as far as I can tell. You're never going to be asked to differentiate those 2 in your exam. Can I explain the difference between derailment and depersonalization? Sure. So, they are very different, actually. Derailment is a type of formal thought disorder, as it says up there. Generally, I imagine this as I imagine a few of the others. Imagine the train tracks. So if you're on some train tracks and it's a circumstantial thought, it will go around in a big circle like a roller coaster, and then they'll get back to the answer. A flight of ideas, you might think of a roller coaster as well, actually, because it'll go like this, but it won't end up at the answer. It'll just keep going and going and going. Derailment sometimes is a bit like loosening of association, where you're on a train, you're going on the rails, they're answering coherently, and you can see where they're going with their thoughts, and then they'll fall off, and you're just like, oh, what happened there? And they just won't get back on, and you'll start on a new rail. And you're like, okay. Night smooth thinking is a sort of like jumping from rail to rail, which might be closely linked, but you can sort of see how they got there, but it's a bit bizarre. Like I said, this is a whole topic in its own. It'll probably take quite a long time to get through all of it, so do read up on them. But like I said, normally one patient wouldn't just have one type of these. No, I'm really pleased you're asking all these questions. So that's derailment. Depersonalization, just to finish up with your question, is different. It's not actually a type of thought disorder, depersonalization. It's a sense, normally it comes under perception. It's a sense that you're not quite real, and sometimes it's confused with derealization, which might be what you're confusing with derailment. It's different. So derealization is the world doesn't feel real, nothing quite feels right, I'm not quite connected with this. Depersonalization is your personal connection. So not necessarily the world not being right, but it's not, I'm not who I am, I'm not feeling right. It's like that. But so make sure you get the difference between derealization and depersonalization and derailment, because that's where the difference is. Thought withdrawal, insertion, and blocking we normally call that under thought interference. So that would it can come under thought disorder, formal thought disorder. I would give you a mark if you said it there, but it's sort of a half a mark, but depending on how generous you want to be with yourself. So yeah, I would say it's under thought form. It's not, is it a type of thought disorder though, or is it part of a delusional thinking there's something interfering with their thoughts? It's a bit less clear. So give yourself half a mark for those ones. Tangentiality and derailment are slightly different, because tangential is you're mildly going off the rails and you're just gradually going off more and more and more, whereas derailment is you suddenly sort of fall from one rail to another. like I said, it will be quite obvious in any question. You're not expected to be an absolute expert on this and be able to detect the subtlest differences. So don't worry about that too much, but hopefully it will be fairly obvious. But do look up more on that and read more about that if you have any questions on it. Hopefully by now then you've looked at number 2 and the auditory hallucination one. Third person, first person, second person is normally the classic. Normally a third person one is people talking about them, or they might be talking to them, but that's actually talking about them. That's third person. Second person will be talking to them, sometimes in a running commentary, sometimes it will be just talking about, saying, you're doing this, why are you doing this? And first person is normally hearing their own thoughts. The thing to distinguish with this is that in psychosis, it's normally perceived externally. And so that's a good question to ask if it comes up in an OSCE. Are you hearing the person inside your head, or are you perceiving them somewhere else, like you're looking around the room, but you know you're not listening to your own thoughts or inside your head? So it's a good question to ask, externally perceived or internally perceived, inside or outside your head. So last question on this is primary hallucinations. Yeah, I mean, I would say that's the other one I'd give you a mark for that. So, and yeah, primary hallucinations is thinking about, primary hallucinations would be thinking, yeah, it's where is that coming from? And is it related to a delusion? Is it related to something else? Like, I'm not going to go too much into that now, but you could have answered this question this way, so I'd give you a mark for that. And yes, a running commentary is normally he's doing this now, he's doing this now. So you could argue that's third person, to be honest. I wrote that to try and be helpful. As long as you understand the difference between third person, second person, and first person, and the fact that it might be them talking to them, a discussion, a running commentary, thought echo, that's okay. Thought insertion broadcast is thought interference, so someone is interfering with their thoughts. In terms of how thoughts are formed, you could argue it affects thought form, so it's part of thought form, but I wouldn't say it's thought stream. Hopefully that answers your question there for that one. So thought stream, we don't really use that word, to be honest. So we normally say thought form, formal thought disorder, or we say thought interference or something like that. Persecutory hallucinations, so that's more, I mean, I could give you half a point for that. It's a bit, I wouldn't normally say that as a way of describing auditory hallucinations, but I mean, partly what this is meant to do is open up thinking about it and opening up the discussion as well. Persecutory is normally more part of the thought content and the delusion, and a hallucination might be related to that, but it is a slightly different thing. And I wouldn't normally describe a hallucination that way. So, but if you're generous, you can give yourself half a point. Although everyone's then getting at 100%, aren't they? We'll see. It's not actually about that. It doesn't really matter what mark you get. Like I said, really have no vested interest in that one. Let's finish up with this because it's going, lots of questions, so great. 3 prognostic factors for schizophrenia. So here are some answers. And when I put this in, it was all in bold, and I have no idea why. So sorry about that. So you've got your ones there. If you said anything else or any confusions about that, put it in the chat. The main prognostic factor, which doesn't come under this sort of risk factors, but the main thing which is clearly associated, this kind of comes under insidious onset, but the duration of untreated psychosis, that might well come up in exams. If the duration of untreated psychosis is longer, that is all the evidence quite strongly suggests that is associated with a poorer prognosis. So if someone isn't treated or undertreated or taking drugs or refusing medication for a long period of time, it's more likely they're going to be more disabled with symptoms moving on. So insidious onset is probably what that one's comes under. But if you put duration of untreated psychosis, that would be amazing. But any of those will also get you 3 points. It's a bit of a hard one, that one. I'd be quite, if anyone got all 3 or got all that list, please let me know, but that would be very impressive. Okay, so I'm going to move on. I got all 3. Very impressive. Well, you were a good Googler, or you know where to get that information. But you're clearly doing well.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.